I did put a little section on adaptive cellular therapies, which include CAR T. So these are a few cellular therapies that have come up in last few years. So donor lymphocyte infusion is extension of stem cell transplant in patients who have received a transplant and have some disease relapse. So we essentially get the lymphocytes from the donor and give it back to the recipient to control the disease. Lymphokine activated T cells. So we get the T cells from the cancer patient and put interleukin-2 and then enrich the cells and give it back to the patients. Tumor infiltrating lymphocytes are for solid cancer patients in which we resect the cancer, remove the T cells from the cancer itself and enrich and expand and give it to the patients. T cell receptor technology, which the prime examples of these things are CAR T therapies, in which we get the T cells and put a special and engineer them to put a special receptor on them and then put it back to the recipient. Most cellular therapies work in a way that you get the cells, you get them into the lab and put special activators or transducers and then put the cancer cells back after a little bit of chemotherapy. And then these are the FDA-approved CAR T products that are available for B-cell lymphoma as well as multiple myeloma. The blue ones are for multiple myeloma. The red ones are for B-cell lymphoma. The gene therapies are another exciting avenue in the world of adaptive cellular therapies. So these gene therapies get the cells from the stem cells from the patient themselves and put special normal genes and then infuse those stem cells back to the patient after a high dose chemotherapy, just like a myeloablative chemotherapy that we talked about for stem cell transplant. So it's a form of an autologous stem cell treatment after doing special modification on the genes of these patients because they have abnormal genes. So we are using them against sickle cell, we are using them against hemophilia and beta thalassemia patients. And the outcomes for all these gene therapies in a short-term follow-up are pretty good. And then finally, we have a tumor infiltrating lymphocyte approved for relapse refractory malignant melanoma, which is a skin cancer. And we do what we talked in a couple of slides ago. We resect this cancer, get those T cells from the cancer, and then infuse those T cells into the patient who has metastatic disease to keep the other sides of cancer under control. The toxicities with the CAR Ts are usually what we call CRS, which is a really bad flu-like syndrome, and a neurotoxicity, which is a constellation of symptoms, including going from confusion to deep coma, and we watch for that very carefully. And then other side effects are infection, cytopenias, and low B cells, especially for against in the non-Hodgkin lymphoma CAR Ts. Delayed onset neurotoxicities and other neurological effects are being seen with the new products as well. CRS is a multi-system a problem that usually presents with fever, shortness of breath, or low blood pressure, but can involve a lot of other organs at the same time. And then mechanism of CRS is increased release of different cytokines in the blood, and mechanism of ICANS is the CAR T cells going into the crossing the blood-brain barrier, going into the brain and producing all those cytokines. Again, gene therapies, we talked a little bit about it, but this is one of the trials from sickle cell disease patients, and we have the longest follow-up on a patient up to 48 months, and they are doing well without having a lot of side effects. It doesn't cure them completely, but it definitely improves their quality of life. And with that, I will I'd like to thank you all, and I will be happy to answer any questions during our panel discussion. And special thanks to Dr. Al Juhaishi, who helped me with the slides.